it pretty last minute. So I do appreciate you guys for that. Um, so yeah, without further ado, I'm gonna go ahead and get started. So I've tried to split this up best I can, but a lot of the concepts, big picture, are they do overlap a lot. So we're really going to focus on those constant reoccurring themes because those are what's going to be tested on, if you will. If I was a professor trying to figure out, oh, what question should I, talk to these students about, it's probably going to be the stuff that we repeat over and over and over again. So I did flip your review just a little bit. I wanted to start with STIs because I think they really help lead us into this issue of like kidney issues and bladder and urinary issues and all the above. So really, I recommend knowing what is nationally notifiable. It is bound to reappear on ATI exams and public health ATI exams and all of that. So it's really helpful to know what's nationally notifiable and what's not. Also, certain STIs can be treated with expedited partner therapy, and others actually do require an office visit. Tip of the trade, if it requires an injection, they're going to have to come into the office. A major complication is PID and infertility if left untreated. And really, how do we keep everyone safe? How do we keep the patient safe, their partner safe, the nurse safe, everyone safe? Safety is a big issue. I listed our notifiable STIs for you guys. That's going to be our chlamydia, our gonorrhea, our syphilis, our cancroid, and our HIV. Also, just be aware that different states have some also that are considered nationally notifiable. Okay. Again, major complication is going to be PID, physical and emotional distress, infertility, etc. And like we talked about, expedited partner therapy, this is when a patient goes in and they get a diagnosis of an STI and require oral antibiotics to treat it. Well, what they'll do is if it's usually oral antibiotics, they'll give that person double the dose so that they can split it in half and give it to their partner so that each is getting this medication that they need. So first up is our syphilis. And syphilis, unlike some of the other STIs, has some of these really odd symptoms, especially in that like tertiary latent phase. If left untreated, we will actually see some neurosyphilis. Okay. Again, very, very general. We've got our primary, which is just that localized canker. We've got some systemic illness, some early latent, etc. So really super important that when we are getting like a specimen of the sore that we're wearing gloves, we're keeping ourselves safe, etc. Also, remember in this secondary stage, we'll actually see some weird rashes, okay? So it kind of goes from, a normal finding, we see like a little skin lesion, and then we start seeing like some more skin abnormalities, and then we start seeing these really, really severe symptoms, okay? So what do we need for these patients? They will need one high dose of penicillin G and then a follow-up evaluation, okay? Usually we need to prophylactically treat within 90 days of exposure because you'll start seeing these stages progress further in the infection, okay? Remember, penicillin G, you usually give that in an injection. So would this qualify for expedited partner therapy? It wouldn't. We cannot send someone home with an injection to give to their partner. Up next, we have our chlamydia. This one is interesting because it's got quite a large incubation period. But like a lot of our STIs, we're really concerned for pelvic inflammatory disease, ectopic pregnancies, etc. Usually, chlamydia infections happen a lot with gonorrhea infections. I'm not sure exactly why that is, but that's just the way it is. But you'll see a lot of discharge with a chlamydia infection. So this is a little bit more standard, where when we talked about syphilis, we started having these really wacky symptoms, okay? So if a patient comes in with those wacky symptoms, you might kind of start thinking what might be happening. Chlamydia, on the other hand, these patients will require some doxycycline or azithromycin, oral antibiotics, and these, fortunately, do qualify for expedited partner therapy. Okay. It's really important to note, though, that these drugs take a little bit of time to work, usually a week, so we want to teach the patient to refrain from having sex for a week. And if they absolutely cannot refrain from having sex for a week, using appropriate protection on both ends. Okay. And then up next we have gonorrhea. Gonorrhea, our hallmark sign and symptom, is usually a yellowish to green discharge and some urinary symptoms. Okay, but keep in mind it's not just limited to the genital area. You can actually get it in your throat, things like that. And again, like I mentioned, chlamydia and gonorrhea usually coexist, if you will, as infections. So usually we're going to screen someone who has gonorrhea also for chlamydia. For this one, these patients will require an IM ceftriaxone injection, and they can also have some oral antibiotics. Keep in mind, though, that with chlamydia, we actually will start seeing some GI issues going on, such as diarrhea, bleeding, itching, irritation, etc. Okay, and it's really important that if they suspect these symptoms, that we provide like a safe environment for them. We do our tests, we wear our gloves, things like that. And our main focus is going to be on this pelvic inflammatory disease. So essentially, if the infection remains untreated, it's going to cause infection in our pelvic area. Well, what happens after infection? We have a lot of damage, a lot of scarring, and it can lead to infertility, ectopic pregnancy, even sepsis and death, okay? So usually we'll do a pelvic exam for these patients, and we'll actually be able to see kind of that inflamed, irritated area. And they'll have some other odd signs and symptoms, okay? What's really important to know, though, is we need to check for pregnancy beforehand. That's a really important factor, okay? We can also do an ultrasound for these patients. So, unfortunately, if the STIs or whatever's causing this PID progresses too much, our last resort is our laparoscopy. And this is usually for high-risk individuals, okay? Not everyone with pelvic inflammatory disease will need to stay at the hospital, but it's really, really, really important to know what factors do we have to consider when we're deciding whether or not to admit someone, okay? We hospitalize or admit a patient with PID if they can't follow treatment. Maybe they have some sort of mental disorder, or they don't have a safe house to go to. Or if they have or if they are indeed pregnant, have severe illness, or have any sort of abscess. So those are some things we need to keep in mind. We're thinking, well, what patient do we want to admit versus who can we send home with some oral antibiotic therapy? And pain management is really important too for these patients. So I have a practice question for you all if you want to do it with me. Don't mind what's highlighted. It always, for some reason, when I copy and paste it, it always highlights the middle one. So don't worry. We have a 21-year-old male client visits our campus student health center reporting discharge. He reports pain on urination and has been diagnosed. Hasn't been diagnosed with anything yet. And he's prescribed IM ceftriaxone and oral azithromycin. He reports relief that no one will have to know about his diagnosis. So while it didn't explicitly say what he had, we can kind of look through some signs and symptoms. We noticed that he had some discharge, and we also know he's being treated with IM ceftriaxone and an oral antibiotic. So I think it's pretty safe to say that he either has chlamydia or gonorrhea infection. So um, let's do it. Mhm. Yep. So we're thinking that this is the gonorrhea because he's being treated with that ceftriaxone. And what do we think we need to provide further patient education on? This is kind of the role of the nurse. Absolutely, Ray. We want to educate on expedited partner therapy. We know that chlamydia and gonorrhea are nationally notifiable. So we need to get further information. Hey, you're not out of the woods yet. Okay, we need to know who you've come into contact with so that we can start treating them for it as well. So I have the rationale and the answer here for you guys. But we talked about it. All right, I have a PID question. 25-year-old female is hospitalized for PID after exposure from a new partner who disclosed having an STI a week after unprotected sex. Initially, upon admission, the client reported lower back pain, dysuria, and new onset of discharge. The client reported lower abdominal pain, dysuria, a fever of 100. So, do we think that so that was her history. We implemented some awesome nursing interventions. Do we think, based on our assessment findings, do we think that our treatment was helpful, didn't work, or not related to this PID? So, do we think a white blood cell count of 8,400 proves that treatment's working? It's not working? What do we think? Good job. That white blood cell count is within normal limits. What about my patient reporting that their abdomen is less tender? Absolutely. It's effective. Very good. We know that it's usually really, really painful for these patients. What about my patient is reporting drinking 1 to 2 liters of water daily? What do we think about that? We actually do want these patients drinking lots of water. It's going to kind of help clear out the tract and do all of that. We also knew that she had dysuria, which was painful while urinating. Um, so the drinking fluids is actually good in this case, just because we know that she was having like dysuria, some difficulties with peeing, and now that she's drinking a lot, that's going to kind of help. And we know that preventing like UTIs, like with STIs, all of that, we're encouraging fluid intake. Um, I know your professor talked a lot about like we just really want nice clear urine. Um, What about laying in the supine position? And to know that the supine one can be a little bit tricky. Absolutely, we want her in semi-Fowler's position. We want her up. If she's still laying in supine position, it means that she's in quite a bit of pain and she's not kind of getting up. We also know that she's receiving some antibiotics, so we want her up. And finally, what about contacting the family member to visit? Absolutely unrelated. Awesome. You family's gonna come sit with you, keep you company. That's great, but it's not gonna help, harm, or do anything to your PID. So very good job. Very good job. And a little bit more of the rationale for the water. She is on antibiotics, so encouraging fluid intake is super important. Unless it's 8 family members. I don't know. I guess they're all having a party because she got a PID. So, little PID party. Um, Also, we don't have to do practice questions if you guys don't want to. I feel bad that Ray has to respond. I know there's only 10 of you, but just pop it in the chat. Like I can skip practice questions. I don't mind skipping them. I sent out a survey for my last class, and they told me that they didn't like practice questions. So we really don't have to do them. Up next, we are going to talk about some acute urinary problems. Why are we concerned? Well, we're concerned if it travels up, if it travels north, okay? We've got our urethra, then we've got the bladder, and then we go up our little ureters, and then we got the kidneys. So if it progresses upward, it could potentially get to the kidneys, and that's not what we want. We're also going to review the options for treating stones and the different issues based on anatomical location. And then really reviewing a quick focused assessment on bladder trauma. So when we're talking about a complicated UTI, this means that there's an anatomical issue predisposing my patient to UTIs, okay? Obviously, severe complications include pyelonephritis, severe kidney disease, damage, and sepsis. What's most important that we do as nurses is do a clean catch urine sample where they wipe, they pee a little bit, and then they place the cup under the stream and fill up the rest of the cup. It's really important that we are assessing for a left shift in the white blood cell count because that shows that early little baby white blood cells are being produced and that there is a current active infection. Okay. Really, we're going to assess their urine status and look for white blood cells in the urine. Okay. Our drug of choice for UTIs is our Bactrim, which is our trimethoprim sulfamethoxazole, and that really helps a lot with UTIs. Warm sitz baths helps a lot with the pain. I know usually they don't want patients to sit in baths because that puts them at risk for UTIs. But with these complicated UTIs where it's like a chronic issue, really these patients do benefit from a warm sitz bath because this is very painful for them. If talking about pain, we can talk about phenazepyridine. Just note that it does turn the urine orange. And why would we give an antispasmodic? Because the bladder and the urethra are probably spasming, and that is what is contributing to the pain itself. Okay. If the patient, if it is quite structural, they can have a cystoscopy done to help kind of scrape out the area and, clean it all up. Really, there's no great water consumption. 2 to 3 liters of fluid is good, but really just make sure that they have pale urine. Okay. Up next is urethritis. This is just inflammation of the urethra, most often caused by the STIs that we just learned about. Okay. So what might we also see? Some drainage, some itchiness, also white blood cells in the urine. Again, What usually causes inflammation? Infection, okay? So we really want to test for some STIs and pregnancy. Why are we testing for pregnancy? If my patient has an STI and is pregnant, it can harm the baby, okay? If it is not caused by an STI, then maybe my patient has some hormonal issues that are contributing to this inflammation. Usually this resolves completely on its own. If it is a hormonal issue, we can actually use estrogen cream on the area to kind of reduce that swelling and irritation if it is caused by hormonal problems. However, if it's infectious, we treat whatever the infection is. And again, what are we concerned about? We're concerning about it to progress to an upper UTI and damaging the bladder, the pelvis, can contribute to pelvic inflammatory disease, all of that stuff that we don't want. Up next is urolithiasis. This is really our urinary stones, if you will. Okay, what we're really concerned about is the larger the stone, it can actually cause an obstruction. So if I have an obstruction that's lower in the tract, okay, this is when we usually have a lot of pain, but it's more beneficial to have this obstruction lower in the tract because it's further away from the kidneys. The higher the stone is stuck, the closer it is to the kidney. So what happens if there's a stone? Urine and fluid can't get through, so it's going to back up into the kidney. All that extra water is really, really going to damage the kidney. Okay. You might also have this renal colic, which is just pain in the kidneys. Usually it's when it's moving, etc. Any sort of alterations in pH and increases in vitamins and minerals put us at risk for stones, because these stones, whether they be struvite stones or whatever, usually caused by increased buildup of something. Okay, so we're really going to be looking for stones in the urine and straining the urine for these stones. Okay, usually water and time for these smaller stones. However, if it's a really, really big stone, they might undergo lithotripsy, which is literally like, I don't know how to describe it other than little lasers kind of being shot and breaking up these stones. And then they're going to fall through the tract, and then we're going to strain for urine. Okay. Thiazide diuretics also help with pushing out the stone, and allopurinol, which is what we use for gout to kind of help reduce those levels and all of that fun stuff. Okay. Really though, we're going to restrict purines because remember, a high purine diet can create stones, things like that. Finally, increasing fluids. And last but not least, we have our good old-fashioned bladder trauma. It's always important to know what the mechanism of injury is. Any sort of trauma to the abdomen or lower abdomen area can harm the bladder. While you don't have time in these traumatic events to be assessing everything about the bladder, one thing we ask, since the time of your injury, have you peed? If so, what was it like? Was it bloody? Was it painful? Was it difficult? Oh, you haven't peed yet? It's been like 12 hours since you got hit in the bladder? Well, I better go get the bladder scanner. Things like that. Okay, if it's extensive, we're probably going to need some surgical repair. If they had surgery, urology will place a Penrose drain or a suprapubic catheter. We don't touch it. We don't remove it. It is urology's deal. They put it in. It's surgically placed. It is beyond our realm of practice. We can assess it. We can monitor it, but we're not going to start manipulating it. Okay. All right. Please let me know if you just want me to skip this practice question. It's up to you guys. Okay, we can do it. All right. A nurse in the urology clinic is providing teaching for a female patient with cystitis. What teaching will the nurse include? Select all that apply. So you've got cleaning the perineum from back to front, drinking enough fluids to pee adequately, completing the full course of antibiotics, calling the clinic if it remains cloudy, expect some flank pain, maybe avoid baths, avoid the sun. What are we thinking? B and C, love to see it, absolutely. Drink those fluids and take all your antibiotics. What else should we teach? So absolutely D, if the urine remains cloudy, we do want to call the clinic. Is flank pain a normal finding in cystitis? And if so, would antibiotics help with flank pain? The antibiotics aren't going to help with flank pain. So we're not going to teach them that. Also, these patients do benefit from some warm sits baths while they have the infection. In order to prevent infection, we usually don't want them to have baths. But we're actually going to encourage warm sits baths for the pain. G, absolutely, our back trim and a lot of antibiotics, a good rule of thumb is practice safe sun because antibiotics make us photosensitive. So we do want to teach them to avoid sun. Also, the phenazopyridine does not help with infection, okay? Absolutely right. It would be relieved with analgesics, which would be our phenazopyridine. Very good job. And then finally, we want to avoid some spicy foods because that could further irritate all of that area, if you will. So very good job, guys. Drink water, take those antibiotics. We want it to be clear. If it's not, call the doc. Practice safe sun and avoid those spicy foods. All right, now we are going to talk about our acute kidney disorders, okay? This is very similar, if you remember, to that fun end-stage renal disease we talked about, but now it's acute. So those end-stage symptoms we actually see pretty rapidly in acute kidney disorders. So really, what are these changes? Well, we're going to focus on them. And then finally, a lot of our care is like cushioning the kidneys, if you will. We want to cushion them. We want to protect them. They're already injured. They're already struggling. We don't want to make matters worse. So we're going to review do's and don'ts. Big picture. So, pyelonephritis, essentially big fancy word for my kidneys are inflamed. Again, what usually causes inflammation? Infection. We talked a lot about lower UTIs. This is why we want to treat lower UTIs so they don't progress and hit the kidneys, essentially. What will we see? We'll see some bacteriuria. In addition to all of these signs and lab values we see when we think of reduced kidney function, meaning increased BUN and creatinine, increased ESR, a decreased filtration rate, some electrolyte imbalances, okay? So think my kidneys are inflamed, they're not working as well as they should because they're infected and they're struggling. So again, if you remember from Complex Health 1, a lot of this stuff still applies. So what are we going to do with the underlying cause? Usually an infection. So we're going to give antibiotics to help treat that infection. If my patient has a Foley catheter in, we're taking it out. Okay. We all know about CODIs. They're really, really not the best. And we want to opt for less invasive procedures first. We give Tylenol for pain. Remember, Tylenol is not an NSAID. There's two things that trash the kidneys. It's NSAIDs and harsh antibiotics, okay? Unfortunately, though, if there's an infection, we need to treat it with antibiotics, but we can call pharmacy and we can talk to them about doing a renal dose, okay? Because of this bacterial infection, these patients are on antibiotics. Whenever you're on antibiotics, we need to increase fluids, okay? We're also going to want to avoid NSAIDs as well. Good. Up next is nephrotic syndrome, okay? Nephrotic syndrome can be caused by inflammation. So what did we just talk about that caused that inflammation? Think about, again, it all kind of connects, if you will. So what's happening with nephrotic syndrome is my kidneys are like, you know what? I'm just not going to filter like right now. Whatever wants to like go can go. Essentially, you had a police officer out there with a stop sign, halting traffic, waving people through. Well, 3 o'clock rolls around, he's off duty, and now it's just a complete free-for-all. Essentially, that's what nephrotic syndrome is. So you'll see massive protein wasting because proteins are big molecules that usually don't get excreted very much in the urine, if you will. That's why you'll see some proteinuria and you see these drop in albumin levels. Remember from kidney lecture? If we're assessing for malnutrition and inadequate protein in the diet, we assess their serum albumin levels. So that's kind of how it all relates. Additionally, we'll see some increased serum lipid levels because of this lipid dumping that also occurs. But think more this protein loss. So what are we going to do? We're going to treat the underlying cause. ACE inhibitors are your drug of choice for the kidneys. They're really good for the kidneys and they help with their promoting kidney function, if you will. They're one of the only cardiac meds that do that. That's why you see ACE inhibitors used a lot. Lipid-lowering agents, we can do some heparin therapy, some mild diuretics, and sodium restriction. A good rule of thumb is if I have a decreased GFR, I'm going to start decreasing some of my nutrients, such as protein, salt, potassium, things like that. Okay? And we're really concerned about dehydration because of this massive wasting that's occurring. Up next, we have hydronephrosis and hydroureter, which is essentially the same thing. It's just depending on where it's at. So with hydronephrosis, we've had a backup of fluid into the nephron, the functional unit of the kidney, usually caused by stones that we talked about earlier. So this is what happens when that backflow kind of goes up. You have increased pressure, increased water, increase all of that stuff, which is going to really cause a lot of damage to the kidney. Hydroureter happens when this stone is a little bit lower, so it's causing swelling in the ureters itself, okay? So it's the same thing, just depending on the location. Usually it only happens on one side, so that's why you'll actually see flank asymmetry, okay? You'll also see a decrease in GFR because once the kidney gets stressed out and filled with backflow, it's not going to function as it should, okay? So you'll start seeing these acute signs and symptoms of renal failure, okay, happening very, very, very quickly. So what are we really going to do? We're going to try to correct the strictures, if that's what's causing, such as a nephrostomy or a cystoscopy to get out those kidney stones. Okay, if the patient does have a nephrostomy tube put in, we never clamp the tubing. Okay, that is essentially a tube that gets like kind of put in to help drain out the kidney, if you will. And again, monitor INOs, protect the kidneys, all of the above. And up next, we have kidney trauma. Again, similar to our bladder trauma, we've got a wide variety going from mild bruising to complete shattering, okay? Really, what are we assessing for? A rigid board-like abdomen, meaning they're hemorrhaging, they're bleeding on the inside from this kidney trauma. Also, you might see some blood in the urethra. And what vital sign changes do we see with bleeding? decreased blood pressure and an increased heart rate. We'll also see in our lab values a decreased H&H and possible red blood cells in the urinalysis, which indicate that there is potential kidney trauma. Okay, so what are we going to do if my patient's bleeding? We're going to give them some vitamin K. We're going to give them some platelets to help. Really, if they're kind of going into those stages of shock, we're going to need some fluid therapy. And if the damage is super, super severe, they're probably just going to take out the kidney, do a nephrectomy. And depending on the damage, people can live with one kidney. That's fine. But if both need to come out, they'll probably be put on dialysis. They'll have to be put on dialysis. Always determine the mechanism of injury and ask, have you peed since this happened? Okay, similar themes to our bladder trauma. Okay, we always assess for complications, monitoring our eyes and O's, making sure our patient is peeing, and we're really looking for some new onset hypertension. Okay. And then finally, we have acute kidney injury. This has a variety of causes, okay? But essentially what happens with acute kidney injury is something happened to my kidneys that is preventing my kidneys from getting some blood flow. Or it can be direct damage or obstruction. So please review your pre-renal, intrarenal, and post-renal, whether it's before the kidney, within the kidney, or after the kidney. That's going to be really important for you guys. Okay. Big sign and symptoms of acute kidney injury is going to be our fluid overload, decreased urinary output, and increased BUN, creatinine, and electrolytes. Keep in mind, any patient that was in shock, had a myocardial infarction, is at risk for acute kidney injury. Remember, we talked a lot about in shock of what is the first organ to go? The kidneys. The kidneys tap out pretty early on when the body gets stressed. So if there's emergency situations, we do dialysis. Now, what's really interesting about acute kidney injury, especially if it's caused by trauma, if my patient is not hemodynamically stable, they're not going to be able to tolerate dialysis where I'm pulling out mass amounts of fluid. So we're going to do CRRT. It's continuous renal replacement therapy. And this is for our really critical patients, okay? And it's done all day long. Okay. Really, how do we lower potassium levels? If we got these critically high potassium levels, we can do a kyaxylate enema. We can give some IV insulin, calcium gluconate, diuretics, things like that. Okay. Really, our main focus, if my patient was in shock or had any sort of episodes of hypotension, I'm going to anticipate an acute kidney injury, so I need to be looking for these signs and symptoms, okay? And for now, we're going to protect the kidneys. How do we protect the kidneys? A good diet, drinking lots of water, avoiding harsh antibiotics, and avoiding harsh NSAIDs. Usually you'll only see fluid restrictions if my patient is like severely edematous or if they're in that end stage renal disease. But with acute kidney injury, we want to protect the kidneys. So that's why we also drink water. But just a rule of thumb, if your patient's on antibiotics, they need lots of water. Now we are going to talk about acute oral, digestive, and liver problems. So really focusing on some comfort measures. We're going to talk a little bit about hemorrhages and assessing for hernias, obstructions, etc. Because that's the role of the nurse. We're the ones doing the assessments on them. So, stomatitis, essentially, it's not super important to know the different causes, just know that they're going to have lots of inflammation and pain in the mouth. So, teaching them to avoid these risk factors is really, really important. Unfortunately, though, we have another branch of stomatitis, which is more severe, esophageal trauma. Okay, this can really cause bleeding and aspiration, pain, etc. Okay. What are we going to do for these patients? We're going to give them their swish and spit, and we can also give them some like liquid diphenhydramine, viscous lidocaine. If your patient has throat trauma or esophageal trauma or bleeding in the throat, we keep them NPO. We need to rest the esophagus. Okay, that's a really, really big thing. Do you have like some varices? Were you coughing up blood? Is there lesions? Maybe my patient's post extubation and there was some trauma with that, and they noted that. We keep them NPO to rest the esophagus. Okay. Up next is gastritis. So essentially, my stomach is quite inflamed. In the acute situation, this can happen from toxins, NSAIDs, etc., where we get concerned if someone has chronic gastritis. All of this inflammation leads to swelling and scarring, which inhibit absorption of very 12 vitamins such as B12. What do we also know about frequent trauma and scarring? Puts a patient at risk for cancer. Okay. Our gold standard for these patients is to get an EGD with an endoscope, and really get an H&H where we're looking for bleeds. Okay. A big complication is a gastric hemorrhage. So it's super important to know what's happening, and that's more common in our acute gastritis situation. What are we going to do? We're going to eliminate the cause. If it's more of like an acid issue that's causing all of this irritation, we can give them some Pepsid and some sucralfate, your proton pump inhibitors, any of the meds to help protect the tummy. What we also know is H. pylori infection can cause gastritis. And if someone has an H. pylori infection, they must be put on 2 antibiotics plus a proton pump inhibitor to knock out that H. pylori. Okay. And in the meantime, if they're having lots of like the diarrhea episodes and whatnot, we put them on the brat diet, bananas, rice, applesauce, and toast. Up next, we have our intestinal obstruction. We have mechanical versus non-mechanical. It's really important to know how to differentiate between the two. With a mechanical obstruction, this means that there is a physical, tangible issue with the digestive tract where there's like a tumor, a twisting, fecal, something physical is causing the blockage. A non-mechanical, there is no physical obstruction, so we know that opioids kind of reduce, like have a constipating effect. If someone had recent abdominal surgery and they did an X-lap or something, just physically touching and manipulating the intestinal tract kind of slows it down a little bit, and it puts the patient at risk for an intestinal obstruction. So what happens with an intestinal obstruction? Well, your poop is moving down the track and then it hits a roadblock. It can't pass. So my body's going to try to do whatever it can to force it to pass. So it's going to create a lot of distension, and it's going to produce a lot of secretions around that area of obstruction to try to push it through. Now, what happens is this builds and builds and builds and builds and builds and can be very painful, can cause distension, and it could eventually perforate. So we will actually hear hyperactive sounds before the obstruction, but then anywhere below the obstruction, we won't hear any sounds. Okay. Really though, we're concerned for perforation. These patients will have really, really severe pain, and then all of a sudden it's not severe anymore, and it's just really, really tender. They're not getting better, they're bowel perforated, okay? And if it perforates, your bowel has like poop in it, your intestines have poop in it. That's not safe for your body. If you will, it's full of bacteria. It's all the stuff my body's trying to get rid of. So what happens if that spews into my abdominal cavity? I can have peritonitis, sepsis, and shock. Okay. It's also important to know that they will have some metabolic alkalosis really high in the intestines and some metabolic acidosis very, very low in the intestines. Okay. So what in the world do we do? Main nursing focus, keep them NPO. Okay. We're not going to try to give them laxatives. We're not going to try to do anything like that. We're going to give them NPO, and we're going to put in an NG tube to help decompress the stomach and get some stuff out. Okay. If they've gone 3 days without food, then we're going to do TPN, total parenteral nutrition. If it's a strangulation case, usually they'll need some surgery. If it's just an issue of slow transit, maybe some metoclopramide. Okay. In the event my patient needs an opioid, we give it with Enterec. Okay. Our big complication, though, is this edematous bowel, which can cause massive electrolyte and fluid imbalances and put my patient at risk for hypovolemic shock. Okay. And finally, in this tummy category, we've got hernias. Okay. Essentially, this is an outpouching of the intestinal tract somewhere, or bowel, whatever. But these patients will actually, you'll be able to feel it when they sit up. So you have them sit up, or whether they might be lifting something heavy or doing the Valsalva mover, you'll actually feel it outpouching. Okay. But it's very important to note like where the hernia is on their body. And we're going to want to assess bowel sounds by the area of the hernia. If you hear absent sounds, this is a medical emergency. Okay. And they're probably going to need a repair, possible ostomy. Okay. Obviously, we do non-surgical first. We're not going to try to go there and like push it back and try to force it back, but we might put like a truss pad on the area, things like that. And what we're really concerned about, though, with a hernia is the possibility for strangulation. Okay. What can help? Core straining exercises. But remember, post-op, we don't want them doing any sort of heavy lifting. So I have a practice question for you guys. So let's do the first part first. You're caring for a 68-year-old patient admitted with abdominal pain, nausea, and vomiting. Patient has an abdominal mass and a bowel obstruction is suspected. You auscultate the abdomen, listening for which of the following types of bowel sounds that is consistent with the patient's clinical picture, or it's consistent with our findings. So if we suspect an obstruction, what findings would confirm our diagnosis of an obstruction? A, B, C, or D? Absolutely, Ray. You are right. We will be hearing hyperactive sounds above the area, but what also will we hear? We'll hear high-pitched, hyperactive areas above the obstruction, but do we hear anything else? Also could have typed this one out better, but we're going to hear high-pitched above and hypoactive below. Okay, so keep that in mind. Remember that. Above, we hear high-pitched, loud noises because all of that gas is building up. It's churning. The like enzyme juices are kind of flowing in that area. And then below, we don't hear anything because there's nothing to pass along past the obstruction. As the nurse, what would our next intervention be? What would the next intervention be? So it's super important to note that if my patient has an intestinal obstruction, we are going to keep them NPO and put in an NG tube. Now we're going to talk about acute inflammatory intestinal disorders. We're really going to talk about major complications of each disorder. Up first is peritonitis. We learned a little bit about it in complex health nursing. One, being a complication of peritoneal dialysis, but it can also happen if my bowel perforates, things like that. So you'll really see a lot of abdominal pain, tenderness, and distension. But what's happening when I have this peritonitis is I actually have third spacing. So fluid moves out of where it should be, it kind of settles where it shouldn't, and it can put my patient at risk for hypovolemic shock. Additionally, patients with peritonitis will have an increased white blood cell count, okay? Lots of different risk factors. Just know that we're really concerned for some forms of shock. So what do? We're going to try to treat the infection. We might have to do a laparotomy, irrigate and drain the abdominal cavity, things like that. Remember, please be looking at your vitals for early signs of shock, as this is a leading cause of death from surgical infection. So please keep that area clean, monitor for infection, etc. Up next is appendicitis. Essentially, my appendix inflames and can possibly rupture. So why in the world is it becoming inflamed? It's when my opening gets blocked, and this can cause infection. Well, what happens if this bursts? Complication, peritonitis. Okay. So essentially, it's really important that if my patient suspects appendicitis, and we have these findings such as this right lower quadrant pain, etc., we want to be monitoring their pain. If at any point they say, actually, I feel great, I have no more pain, oh crud, their appendix just ruptured, and we need to get them to the operating room pretty darn quickly. This is why, even though it's painful and they're in pain, we do have to hold some pain meds for these patients, just because, um, again, we could be missing a very important vital sign. Okay. What are we going to do for appendicitis? Keep these patients NPO. We can do pain management and IV fluids post-appendectomy, but we should not be giving them pain meds before an appendectomy, okay? And really, the reason we're giving this antibiotics after the operation is to prevent peritonitis. Up next, we have gastroenteritis, also known as stomach flu, usually caused by raw or undercooked foods or even recent travel. Unfortunately, our major complication is going to be dehydration. These patients can lose up to 20 pounds in a few days if they keep having these massive episodes of like diarrhea and stuff and vomiting. So we're really concerned for some fluid and electrolyte imbalances. So we're probably going to want to put these patients on a cardiac monitor just to assess if they're having some potassium imbalances. We're going to want to do whatever we can to replace the fluids, Pedialyte, Gatorade, whatever. However, we're going to avoid antidiarrheal drugs. Now, it seems kind of interesting. Oh, well, if they're having diarrhea, we want to help that. Well, if they have Crohn's and they're having chronic diarrhea, absolutely. But why are they having diarrhea? It's because they have an infection in their stomach, and the diarrhea is happening because their body's trying to get it out. We want it to get out, so we hold antidiarrheal drugs. And finally, we can give some antibiotics. I don't know if you've been in clinical and you've seen a patient that's on GI precautions, such as like C. diff or whatever. We know that you have to sanitize the surface with some bleach and stuff because the traditional things won't work to kill it. So hand washing is number one. And up next, we have diverticulitis. This is inflammation of our sigmoid colon, usually when those little pouches get inflamed. Unfortunately, if they get inflamed and infection is present, abscesses can develop. So what happens when an abscess develops? Patients might have risk for infection, things like that. Unfortunately, these pouches can perforate, causing peritonitis and a bleed. So we're really going to be watching for any sort of bleeds. Where would we see, if someone has a GI bleed, where would we see that? We would see positive fecal occult, blood in the stool, rectal bleeding. You would see a decreased hemoglobin and hematocrit. So really, our big focus is bleeds and monitoring for bleeds. Because remember, diverticulosis is a chronic disease. But what happens when they get infected and inflamed? Well, they could potentially abscess and burst. We're really going to put them on a low fiber or clear liquid diet. For severe cases, we keep them NPO and try to get them started on antibiotics. Sometimes, though, they might need an emergency colon resection. Okay. What are we going to teach their patients? We're going to teach them, please come in if you have an elevated temperature or this pain's been lasting for 3 days, or you notice any signs and symptoms of a bleed. Big patient education. Please, please, please avoid laxatives and enemas. They will further irritate the area. And we really just want to rest everything. We're going to want to rest the body. We're going to want to rest the GI tract. So avoid like all of those health foods like oats, seeds, like spices, things like that. It's going to further irritate the area. Okay. It's up to you guys if you want to do this one or not. It's just a practice question about diverticulosis. Completely up to you. Thanks, Ray. It's all good. I know your GI lectures are a little bit later, but GI can kind of be a little bit of a pain. So hope it's a good review prior to class. So, a lot of these questions also help you determine normal versus abnormal findings, and it helps get you a little bit more familiar because I know Miss Droop likes to have more of these style questions connected to bow tie stuff. So, what assessment findings require follow-up by the nurse? You can do 1, 2, 3, 4, A, B, C, D, whatever you prefer. So I usually look at these questions and I'm like, normal or abnormal. So brown liquid, never a normal finding, okay? Um, so very good job with that. So yeah, I'm probably gonna follow up. I'm also probably gonna follow up on his excessive alcohol use. Okay. The temperature, it's a pretty normal temperature, so I'm not too worried. And his pulse rate, 92, is still within normal limits. Okay. However, I am quite concerned that his peripheral pulses are weak. That makes me a little bit concerned. Okay. Additionally, respirations, those are within normal limits. But I do see that his apical pulse is a little bit elevated, so maybe I am gonna follow up on that. Obviously the blood pressure, I really don't like that finding. So yeah, we see some widened pulse pressure, and we really don't like that. So I like that you're picking up on that. That's very good. His O2 sat seemed completely fine to me. Reporting no nausea, that's great. I don't want my patients to be nauseous. But him feeling a little bit lightheaded and weak does make me a little bit concerned, okay? So, we see that he has low blood pressure, weak peripheral pulses, and he is feeling pretty lightheaded. Additionally, um, why I'm concerned about this low blood pressure and this increased pulse, there's something happening that I don't like. So good job making the connection between our widened pulse pressure. You know, he's got weak pulses, but his heart rate's really, really high. Again, he might be bleeding. So very good. I'm thinking bleed. This one's also kind of a fun question because you guys will have like bow tie style questions, extended drop down questions. So, especially as you get towards the end of this semester, you'll start having less and less normal NCLEX questions and more of these. So I'd rather you do them with me in like a little bit of a safe space where we can talk about how to tackle them. So for the first two drop downs, we're going to look at the stuff on, I believe it should be your left of the screen. So the nurse recognized, so a 52-year-old male client had an open partial colectomy and a colostomy created yesterday morning to remove a large tumor in his colon. His wife's at bedside today. What is the most likely options for the information missing? So the nurse recognizes that my patient is at risk for what two post-op complications after he's had his colon essentially taken out, the area's been manipulated. What do I think he's most at risk for? Absolutely. Paralytic ileus. He's at risk for paralytic ileus. If at any point we're manipulating the area of the intestines, they don't like to be touched. There's one other thing I'm also concerned about because he did have an open surgery to the area. We just open up the area and, you know, what might I possibly be concerned about? He had major abdominal surgery. Absolutely. Very good. Peritonitis. Very good job. So, what findings would indicate these complications? What might I see? What three findings do I think I would see when I had this, if I had this paralytic ileus and this peritonitis? What would I possibly see? Absolutely, I'd see a rigid board-like abdomen. Absolutely. There'd absolutely be some distension, 100%, and there would also be fever. Very good job, guys. Very good. So now we get to talk about our acute liver problems. So really we're going to focus big picture on some of the complications associated with reduced liver function. I just included a hepatic function panel for you guys just because you might see it in clinical use a lot, you know. So just know that like our ALT, AST, all of that fun stuff kind of gives us a bigger picture of what might be going on with the liver. So, for those of you that don't know, what in the world are the functions of the liver? So, the liver metabolizes a lot of our drugs, proteins, fat. Our clotting factors come from the liver, especially. Liver, very good at getting rid of all of those toxins, okay? The liver also helps us produce bile, okay? Bile is very important in excreting bilirubin and cholesterol. Ba, 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 ba. So, if my patient has liver cirrhosis, This means that there's just lots of damage and scarring to my liver. Well, what in the world damages the liver? Hepatitis, alcohol, drug use, all of that stuff. So, what am I most concerned for with liver cirrhosis is what we call portal hypertension. So, it's high blood pressure within the portal vein. Okay, this can cause esophageal varices and bleeds. We're also concerned about what we call hepatic encephalopathy. We know one of the big functions of the liver is to help excrete pneumonia, NH. Well, what happens if the liver is damaged and is not doing its function? Ammonia is going to continue to build. Okay. We all remember from Women, Children, Family, those patients, the little bilirubin babies. It's because their liver is still learning how to do its job, so they're jaundiced. So you'll actually see jaundice in patients with liver cirrhosis. What are we really going to be assessing for? We're going to look at their liver function stuff, their LFTs, bilirubin, ammonia, things like that. These patients also will gain lots and lots of fluid, which is interesting. So what are we going to do? We're going to put them on some diuretics to help get the fluid off. Paracentesis helps. What is really good at getting rid of that extra ammonia buildup? Lactulose. So if someone has ammonia, we give lactulose, okay? So big nursing considerations, monitor fluid and electrolyte imbalances, and teach alcohol cessation. Next, we have hepatitis, different types of hepatitis, all of which damage the liver. Okay, so if we have hepatitis, we're really going to look at one, does my patient have hepatitis? We're going to do antibody antigen test. And then really, we're going to look at the liver. We're going to see, okay, how much did the hepatitis damage your liver? Okay, what are some signs and symptoms? Some weight loss, fatigue, tummy pain, things like that. So what in the world can we do for treatment? Well, we're going to give them some drugs for hepatitis, antiviral and immunomodulating drugs, usually your NRTs, things like that. Big picture, we can get vaccines for some forms of hepatitis, but proper hand washing is the best. For these patients, since they are very malnourished usually, we want high calorie, high carb foods, plus lots and lots of rest. Up next, we have fatty liver. There's two different types of fatty liver. One involves inflammation and one doesn't. So non-alcoholic just means there's no inflammation. Non-alcoholic FLD. Non-alcoholic steatohepatitis, this involves inflammation, okay? But what's the big problem with fatty liver? As you can see, it's grown, it's swollen. When things grow and get damaged, scar tissue happens. So this is why it can progress to cirrhosis, okay? So all I would know is that if your patient has a really big history of alcohol use, we're probably going to assess for fatty liver. We're also going to look at their triglyceride panel, okay? We're going to try to give them some lipid-lowering agents as well. But a lot of our focus for this fatty liver disease is going to be focused on prevention because it's pretty darn preventable. And finally, we have our liver transplant. You can get a liver transplant. Usually patients with severe cirrhosis will opt for a liver transplant. However, like all transplant recipients, we teach proper hand washing. You're at risk for infection due to your immunomodulators, watch for rejection, things like that. However, what do we know usually causes cirrhosis? Alcohol use. So if my patient is still struggling with chronic alcoholism, they're not going to be a good candidate for a liver transplant. We want to, work on that first because that's such a, goodness gracious, it's such a complex thing to go through. Multifaceted, if you will. Similar to our kidney transplant, any sort of transplant, these patients are at risk for infection due to those immunomodulators. Really, we're going to watch for acute graft rejection. If we suspect acute rejection, we're going to try as hard as we can to push more immunomodulators and immunosuppressants. Obviously, monitoring for infection, things like that. Additionally, a malfunctioning liver can actually put you into acute renal failure as well. Okay, so just keep that in mind. Main takeaway is if you received a liver transplant, please remain free from infection, stay safe, and take your immunosuppressants. So again, I know you haven't learned about this yet. It's up to you guys if you want to tackle this question or not. But it is a question about preventing transplant rejection. It's up to y'all, whichever you want to do. That's okay. Totally understand. We'll skip it. Boop. Ba-doo. Oopsies. Not really sure what's happening right now. Yeah, no problem. Right now, my little computer's having a little bit of a timeout right now. So let me. There we go. Okay. So now we're going to talk about some acute biliary and pancreas problems, really focusing on exacerbation, septic shock, and life-threatening complications. So, what in the world is cholecystitis? Essentially, my gallbladder is inflamed. So what in the world does the gallbladder do? It helps produce bile. Bile helps my intestinal tract break down stuff. So we've got my intestines, we've got my gallbladder. Essentially, gallbladder, delivers bile to the intestines so that my intestines can kind of break down food, churn it up, break it apart, and make it just totally easy to get excreted, essentially. So that's what your gallbladder does. Cholecystitis occurs when my bile duct gets obstructed. This causes all of that bile to back up, have a major backflow into the gallbladder, and become very, very inflamed. In the chronic situation, usually caused by gallstones. Okay. This is also important why we assess for some risk factors with these patients. Additionally, what in the world happens with these patients that is pretty hallmark of cholecystitis is they usually have a lot of pain after eating really, really fatty foods, okay? And it can be radiating, if you will. They'll also have a positive Murphy sign, which happens during palpation when they hold their breath, okay? You might see some Bloombergs, which is rebound tenderness to the area. But essentially what happens is these high fatty foods cause lots and lots of irritation and cause my patient to essentially have lots of fat in the stool, if you will. Okay. While my patient is still having really bad nausea and vomiting, we do want to keep them on clear liquids and slowly progress their diet. Okay. If they need a cholecystectomy, we really just monitor for complications. Laparoscopic is the way to go because there's less complications, it's less painful, less risk for infection. Okay. But keep in mind, this patient essentially had bowel-related surgery. So afterwards, we keep them NPO till we know their bowel function returns. We want to hear them passing gas. We want to hear sounds. We want to hopefully have them do a bowel movement for us. That would be like the gold star of your bowels working. Okay. Big part of patient education, high fat foods. We want small or avoid high fat foods. We want some small, frequent, high fiber meals to help add bulk to the stool. And if they have an incision, please, please split your incision. So, pancreatitis is very, very common, actually. Essentially, the pancreas itself gets very, very inflamed. Can be caused by multiple different things, such as an obstruction, trauma, or alcohol. But I really want you guys to be able to make the connection of an acute infection on the inside of the body and put my patient at risk for sepsis and MODS. Sepsis can contribute to hypovolemia, which can then cause an acute kidney injury, and it's really, really, really not good, okay? These patients have lots of pain, but it is worse after eating. And you might see lots of bruising on the flanks. We really only see that in acute pancreatitis. Amylase and lipase are big pancreas enzymes. So if you see some abnormalities with those, somehow the pancreas is involved. Okay. Our goal really is to decrease GI activity to help decrease my pancreas, stimulation. We can give them stuff for pain, but we're going to keep them NPO and we're going to help decompress the stomach, okay? A lot of our GI content is going to be about, in the acute situation, reducing stress on the GI system so that it can heal. We can figure out what may be going wrong, all of those things, if you will. So what are we going to do after kind of we've gotten out of this acute phase? The broth diet's really good, decrease fats, things like that. And that's more for your long-term stuff. Up next, we have our pancreatic pseudocysts, and these are quite scary. But fortunately, they do resolve on their own for the most part. However, they can rupture and cause my patient to hemorrhage. Okay. How do we see this mass? We see it on a CT scan. So, fortunately, a lot of this is going to be a waiting game. Within 6 weeks, it should, drain on its own and return back to normal. However, if it's still there after 6 weeks, we're going to need to drain it. Why do we have to drain it after 6 weeks? Well, it's because we need to drain the fluid so that it doesn't rupture and make my patient go septic. Okay? Also treating with antibiotics and pain meds. And last but certainly not least, we have our pancreatic abscess. We talked a little bit about pancreatitis, but this can be a complication of pancreatitis. It is a very serious complication of pancreatitis, and it can lead to peritonitis because essentially this pancreas, I really don't know how to say it other than it starts to die and becomes necrotic in this abscess area and can really lead to sepsis and death. With these patients, you will see a very, very high fever. So if your patient has a known history of pancreatitis and they have a very, very high fever, we know that we need to send them to the OR right away to get this thing drained. As you can see down below, this area can fill and it fills with necrotic pancreas tissue, if you will. Afterwards, we assess post-op for the drainage site. So I have one question for you guys. I can kind of walk you through it, if you will. A lot of it is kind of going along the lines of priority, which I notice have kind of scored low across the board for a lot of the classes I've helped out with. A lot of it's looking at what's the normal finding and what's abnormal. But we also have, are they stable versus unstable? So I can kind of help talk through it. So a history of colitis, so we're looking at an admission assessment for a patient with acute pancreatitis. What findings are priority? A history of cholelithiasis. It's important, but I don't think a history is super it's a high priority right now, but let's go through the rest of the answers. Serum amylase level 3 times greater than the expected value. Well, that's abnormal, but my patient does have pancreatitis, so it's a normal finding for that disease process, but we can always go back to it. They report of severe pain radiating to the back, that's an 8. While I don't want my patient in pain, that's still a normal finding. And finally, I have hand spasms present when blood pressure is checked. Does anyone remember what that was? It was all the way back from patient-centered care, but it's bound to show up on your boards. Does anyone remember? It's okay if you don't. It's quite from a long time ago. But that's actually our true
Is it
self.
true self sign?
Yes, Ray! I'm so proud of you.
Sorry, I was typing it and I was like, there's no way I'm spelling this correctly, so I'm just gonna
No,
say
you're
true
okay.
sign. Which is
Absolutely.
hypocalcemia.
Yes, yeah, they have their calcium levels are off. And that is an emergency finding because calcium is an important electrolyte in our cardiac system. So that, if we follow the airway breathing circulation approach, that impedes circulation. So very good job.